Good morning, everybody. This is just to let you know everyone is currently muted in case you can't hear anyone. We will allow presenters to unmute themselves as and when necessary, and any questions can be asked through the Mentimeter facility that you can see on your screens at the moment. We hope to be starting in just over 5 minutes. Thank you very much. Welcome, everyone. I'm just going to hand you over to Douglas, who will take us through our initial presentation. Thank you.
Hello. Welcome, everyone, to this special annual general meeting of the System Dynamics Society UK chapter. The first thing to say is that Peter Lacey, who was supposed to be introducing the meeting, unfortunately Peter's internet has gone down. Hopefully Peter's internet will reappear very soon, in which case I'm sure that he will introduce himself to the meeting. In the meantime, can I just welcome everybody? Clearly there's a lot of people here today who would not normally be at the System Dynamics annual general meeting, and you are all very welcome at this strange time. We've got a range of contributors this morning. I'm doing a brief introduction to the structure of the kind of model that people use. And then in order, we have Kim Warren, who will be describing the work that he is doing, which I think involves contributions from across the world. So Kim's doing amazing stuff online for anyone who's not following him. And then we have a contribution from Mark Gregson of the Whole Systems Partnership, who will be explaining how locally people are using system dynamics modeling to support immediate planning, capacity planning, and so on in the health sector. And then we're delighted to welcome, he's come all the way from the Netherlands, which is quite a distance to travel, Pruyt. And Erik will be describing some of the work that he is doing. And again, like Kim, it's well worth checking out Erik's blogs. So we look forward to a range of presentations. I'm now going to move into screen sharing mode, and we're using Microsoft Teams, so that's interesting. I might recommend that while people are speaking, while the main presentations are happening, it might be a good idea for you to switch your video cameras off. My experience of Teams is that having lots of video cameras on can slow things up. So for the presentations, you could switch your cameras off, and for the questions, you can switch yourself back on again. I'm sorry that I don't have my camera on, but there we go. So I'm just moving to screen share. Oh, here's Peter. So Peter, do you want to say something?
Thank you very much for doing the introduction, and apologies. I'm currently working off 4G on my phone, so I don't have presentations.
Okay. Peter's frozen on my screen, so let's move to a screen share. I don't know if somebody could reassure me as to whether they can see my screen.
Yes,
we can.
Douglas.
Right. Excellent. Thank you very much. So I'm just going to start this model running and then describe to you the sort of generic structure of it. It's running for a year, as you can see. The question is, who would be a modeler right now? Models are rarely out of the news, and they're getting a very mixed press. And when all of this is over, you can be sure that people will be looking for others to blame. However, if we're dealing with a complex problem of a new phenomenon where there's precious little data, because there can't be data, models fill the gap. Unusually for system dynamics practitioners, pandemic models come with a pre-packaged stock flow structure. Normally, when we meet a new client, we have to figure out where the stocks and flows are. When it comes to pandemics, this work has already been done. And all of the models that you will see this morning will resemble this in some respects, and they will have this 4 or 5 stock representation of the pandemic or the epidemic. So Typically, this is described as susceptible, meaning the stock of everyone in the population at the beginning. Everyone is susceptible to catching the infection because nobody is immune, there is no vaccine. Moving into a phrase that's sometimes described more typically as exposed, meaning people have been exposed to contact with the virus. I've described it here as pre-symptomatic because it's a period where you have the virus, you show no symptoms, and there is a question about whether or not you can pass on the infection. Moving into a symptomatic period, which typically would be called infected, where you definitely do have the virus, you definitely are infected, although even then some people's symptoms are extremely mild or almost unnoticeable, so that there are people in both the pre-symptomatic or the exposed and the infected categories who are completely unaware that they are carrying this virus and that they are therefore infectious and at risk to the people who are in the susceptible group. And then at the end of the process, which takes maybe 14 days or so, depending on how many days in each of these categories, most people recover and go into this stock called recovered. And here we assume that they might be immune, that they may no longer become infected or for a while, but we're not exactly sure about that, and there will be other people in this meeting who know much more about the latest research on that. And sadly, there's also a stock of people who have died, and we represent this as a stock because we want to get a sense of the cumulative figures. This is a model of the same size as my home city, which is Edinburgh. It's got 500,000 people in it, and at the beginning there were 500,000 people in the susceptible category. By somewhere around about the middle of the year, no more people have caught the virus, and it's stopped at around about 100,000 people who didn't get it. Meanwhile, at the other end, 390 odd thousand people have recovered from it, and sadly 5,000 people have died, and this represents what might have happened had we done nothing. So I'm just going to show you in a couple of minutes a couple of policies and to show you how this model works. And as I say, all of the presenters will have a structure that's a bit like this, and they may or may not want to describe how their elaboration of it differs. So I'm going to run the model for 3 months, and we're now the infection starts at the end of month 2. 5 people visit from the outside world, and it only takes 5 people to trigger this number of pre-symptomatic people. And the only policy we have at the moment is lockdown. So if we impose a tight lockdown, you can see that the spread is contained and the number of people susceptible goes down to about 440,000. And if we keep the model going, then eventually somewhere into the autumn their infection goes away. But we've locked down the whole of society for a huge period, and that may not be sustainable. So you might think, let's try that again. Tight lockdown, move forward for 1, 2 months, and then we think, can we move? So let's just stop that again. The problem with a tight lockdown is that when you try to lift it, so if we take the lockdown, reduce it from tight to medium or light, then the infection starts up again. And there's various possible scenarios here, but what we find is that if you combine a lockdown with a contact tracing policy, first so impose a tight lockdown, bring the infection under control, then introduce contact tracing, then we can begin to reduce lockdown. But actually that's not what you're seeing. So just to go back to the beginning, there's the problem. We have an infection that comes from the outside. It spreads rapidly, and unless we lock down the population, everybody gets it. Fortunately, we've got a number of different model-based solutions to this problem, and I'm going to hand over to Kim Warren. I'll give him 30 seconds notice, and Kim can explain to you what he's been doing in using system dynamics to model COVID and sharing his findings online. So I'm now going to take my screen down and switch off my microphone and pass on to Kim. So this is Kim Warren.
Hi, I hope everyone can hear me. Now I'm faced with the difficulties of actually figuring out which of these many screen sharing options I need to choose. I think it's that one. Let's hope this works. Is that the right screen? Could someone just tell me that they're seeing my slide? It's just got a regional COVID-19.
Yes, we can see it.
Lovely. Okay. First thing to say is that I owe everything I'm going to say in the next few minutes to Maurice Glucksmann, who a few of you may know. Maurice and I worked together also with John Moorcroft. I hate to admit this, but I think it must be getting on for 25 years ago. He was a consultant with McKinsey and has moved on many times since then, but he contacted me about 2.5 months ago saying that he would like to get a better understanding of this COVID-19 thing, and would we have some insights we could draw out of developing an SIR-based model for the disease. And he came along with a slightly more inspiring request here, and basically it's led to the philosophy that's on this screen. What's behind what we're doing is recognition that this disease is threatening millions, if not billions, and those people are basically being told what to do by leaders and experts who they don't understand and they don't trust. And under these circumstances, our feeling is that citizens deserve transparency in all this, and they deserve to be informed. They deserve to understand why they're being asked to do what they're being asked to do. And that means that we need an accessible tool for understanding how COVID outbreaks actually work, and it needs to be local, so that it can actually give some idea of what kind of actionable insights might arise. And it needs to be really easy to use. And the case I'm going to show you in a moment is just one of the latest that has actually been led by high school students. The previous one that we went public with was a model that was done on Jakarta in Indonesia, ahead of the likely government policy to lift lockdown, when there was the risk of 3 million people leaving Jakarta at the end of Ramadan and travelling to the rest of Indonesia and taking COVID-19 with them. So that 17-year-old guy who actually did that work was interviewed last week on CNN Indonesia for the work that he had done. And the government ended up not lifting lockdown and telling people basically to stay put and not take COVID-19 all around the country. This particular, the basic principle then is that disease outbreaks are fundamentally regional and local in nature. London and the southeast is fundamentally different from Oxford and fundamentally different from Cornwall and it's fundamentally different from Norfolk. We've got the four nations, the United Kingdom, making up their own policies. But actually, there's much more similarity between London and Glasgow and Cardiff and Belfast than there is differences. And there's much more difference between London and Oxford than there is between London and Glasgow. And the particular case we're going to look at concerns what may be the largest slum in the world. It's a region in Mumbai called Dharavi. The second point is that health system capacity is also organised on a regional and local basis. People have hospitals that serve their city or hospital clusters that serve their urban area and local catchment areas. And what that means is that policymakers need regional intelligence and policy. Otherwise, you end up with what we've had in the UK, which is policy being driven by data and evidence of what's going on in London. And what we mean by a region, it's quite difficult to do this. Essentially, what we mean by a region is as a defined area where the daily traffic in or out of that area is relatively small compared with the internal population mixing. That's a pretty hard criteria to hit, to be frank. We've done the model on Greater London, and we've managed to match Greater London really pretty well. But even there's obviously a lot of commuter traffic crossing those boundaries every day. But that's the ideal circumstance. So where we're looking at is a part of Mumbai called Mumbai City District. It's the kind of downtown part of Mumbai. And on the right-hand little map, you can see an area called Dharavi, which has a population estimated to be somewhere between 700,000 and 1 million people. The only reason that the population isn't bigger is you simply cannot cram any more people into such a small area. That's a population density of 250,000 people per square kilometre. And it is right next to one of the most affluent city areas in India, Mumbai City District. And of course, the residents of Dharavi until recently have been, they basically serve the residents of Mumbai City District. So how is the outbreak actually going in these two different areas? Now, I've got very little time, so I can't go through the full detail of this. But we've got completely different circumstances in these two neighbourhoods, even though they are just hundreds of metres apart. In Mumbai City District, excluding Dharavi, we've got 2.4 million people, stabilising, slightly declining population. A pretty old age profile, the average age is 45 years. And the calculations imply that life expectancy is 80, but we're a bit sceptical about that. But it's a pretty old population, and there's significant emigration from that district. Dharavi, on the other hand, has life expectancy of 39 years, an average age of 30, with very high levels of child mortality. And you can see there that the birth rate and migration rates are quite different between those two. Obviously, there's very high mortality from cholera, dysentery, and other diseases in Dharavi. And the reason this is so pertinent right now is that probably today or within the next few days, the monsoon is going to arrive. And the monsoon will flood Dharavi, all the sewers will overflow, rates of infection from those horrible diseases will escalate. And now they've got COVID-19 on top of all that. So what policy could Mumbai possibly have to mitigate the harm in these two very different districts. So as I say, I've got to go pretty fast here, but this is the result of essentially the kind of SEIR model that Douglas explained a few minutes ago, running from left to right. And never mind the differences in the colours just for the moment. This is Dharavi, where you've got 250,000 people per square kilometre. There is no possibility whatever of social distancing here. It's just impossible. So the Indian government imposing a lockdown strategy on Dharavi is nonsense. They can and have essentially locked down the district from the rest of the city. But if you look over to the right, you end up with 7,000 to 8,000 people dying, no matter what you do. Basically, COVID-19 is going to rip through this. Well, it already is. It's already ripping through this slum at a heck of a rate. So what might you do? Well, there might have been a case for early lockdown release. That's the orange scenario in these charts, and you can see there's a huge peak in new cases in the second chart along. It does result in the highest number of deaths, but it's not that many more than a gradual release of the lockdown. And that might that obviously sounds a bit callous. If you're one of those couple of hundred extra people who die, that's not good. But the important thing is that on the left-hand side, there's nobody left susceptible. Now that means that everybody left would not have the risk of COVID-19 on top of dysentery and cholera all at the same time. So it's very likely you would save many more deaths from those other causes. Unfortunately, you can't do that because it's too late. If you had done that a month ago, it might just have worked, but it's too late now. The peak of the infection is going to coincide with the monsoon. So effectively what they have to do is the gradual release scenario. That's the blue scenario on here. And what can city authorities do? Well, the very best thing they can do is urgently get those sewers cleared and support the population with food supplies and medical supplies and as much medical care as is possible to provide within that district. The pink scenario says, well, maybe we really ought to see if we can delay this whole thing until the worst of the monsoon has gone. Unfortunately, if you look at the lower left chart, which is the degree of social distancing that has to be achieved, you have to reduce people's contact rates to less than 10% of what they would normally be for getting on for 2 months in order to delay that peak of infections until after the monsoon has passed. And that just can't be done. It's impossible. And the hospitals serving the area are at capacity all the way through this, and they've got all the other diseases. So Mumbai City District, completely different. Notice first of all that the disease actually arrived there earlier. It's believed to have been brought back by holidaymakers returning from skiing holidays in Switzerland. And this kind of looks like many other somewhat affluent, certainly not poor cities throughout the world. And you could just release the lockdown, and I should say 23rd of May, I think. And then just let it go. But then you have the same kind of surge in cases in the orange scenario, and you get 32,000 deaths on the top right. With a little bit more care, with gradual release of the lockdown, you could pull that down to something like 27,000. And we presented this to the authorities actually trying to manage the disease in Mumbai a few days ago, and discussed with them the kind of pink scenario, which is kind of sustained vigilance policies, and that means things such as Douglas mentioned, test and trace, and also hygiene measures. I'll say a bit more about hygiene in just a moment. But in this case, it is possible to significantly reduce deaths, and the real point of the pink scenario is that you keep the case rate below the capacity of the hospitals. The reason the death rate in the blue scenario and orange scenario gets so high is because a lot of people cannot be cared for in a hospital. They basically have to get through it at home, and the mortality rate at home is much higher. So here we've got completely different strategy implications for two districts that neither of them are very big. We're talking about a few square kilometres in both cases, right next to each other. You can just read that one while I'm talking, but the middle band is quite important here, and that is we saw that the citizens of Dharavi will basically be through this in a matter of weeks, and largely resistant. There's some question about how long people remain resistant to COVID-19, but that would mean that they would be free to interact with the rest of the city again, and that is important for their economic well-being. People need to work, to eat, to live. The further questions for Mumbai City District are rather more kind of nuanced and tricky, like to what extent should testing and tracing be done, and how much faith can you put on it? How much impact? Maybe it's a good idea to isolate the most vulnerable people. That might pull the death rate down. And what might better hygiene measures contribute? So what we've tried to do, as I said, is make this a completely transparent model. And key to this is this blessed R number that the politicians and advisors keep on talking about. And apart from telling people it's the rate at which the disease spreads, that's a completely unhelpful explanation. So what we've done is made it very transparent with this simple little story. 100 people are infected, each meets 4 other people per day, for example, and when we say meet, it is close enough for the virus to jump if it did, which 10% of those contacts actually result in the virus being passed. So you end up with 40 actual infections per day from those 100 people. Those 100 people stay infectious for, let us say, 6 days. That's not a COVID number, 6 days. People stay infectious for longer than that. But if it were 6 days, that's 240 newly infected people from the 100 who were infected. So the R0 would be 2.4. That's the number of people infected by each already infected person if everybody else was susceptible. If only 50% of the people they meet are susceptible, others being resistant, that brings the number down to R, which is 1.2. Now, that we've done this little article that you can go and read at sdl.re/R0 unpacked. And we've written that for non-specialists to understand. But we're trying to demystify this, and this is a very simple piece of arithmetic. We're not talking about advanced statistics here. We're talking about basic sums that anybody can do, and that's in the model. Now, what that means we've got 5 items there, all of which we can actually do something about. So we can get infected people to kind of stay away from others. We can reduce the contact rates. We can do things with hygiene measures such as wearing masks to cut the fraction of people who catch the virus from contacts. We can get people to stay isolated themselves so that their infected period is less. And we can do something about keeping people away from susceptible people. So instead of kind of playing golf with this one club, which the government seems to be doing with their obsession with lockdown and nothing else, you've got a lot of clubs in your bag. So hit the darn thing with every club you've got. So the model, it's, as I say, it's a standard SCIR model. The first thing we did was match it to the Imperial College March model, but we added to that evidence for the time distribution of virus incubation and the time distribution for recovery and death, both of which are quite important numbers. Importantly, we split out the behaviour between people who get very mild or no symptoms at all. They essentially carry on with their normal contact behaviour, unless told they can't. People with mild symptoms who basically stay off work or school, and severe cases. Now that means that we can put realistic levers in the model for the impact of hygiene measures such as masks, voluntary and enforced social distancing and isolation, and everything in the model is exposed, everything can be changed, and you can push through time-based changes through the model. Where we're going next from this, first of all, just go get the model. It's at that link there. For anyone who's completely new to these SIR models, there's a very, very basic SIR model at the right-hand link there. And our aspiration all the way through here is to put this in the hands of ordinary people. So we're currently in discussion with an organisation called Junior Achievement, which is basically a worldwide network of to support young adults to help them get on in life, kind of outside of the educational hierarchy. We're seeking, we've got some support already from PwC and Standard Bank in Africa and from Capgemini to get this out. So please just use it, please use it, and tell us the results you get. We are looking for volunteers for other cases, it is still basically just being done by Maurice and myself and a few friends who are kindly giving their time to help with various city calibrations of the model. We need a proper infrastructure and dedicated resources, but we're struggling to find where we might get that from. So that's it. I apologise, I've probably overrun my time. I'm sorry.
Kim, it's Peter Lacey, yeah?
Hiya.
I think online with Wi-Fi. Perhaps you can mute yours. I think we've got some technology here.
Yeah, I'm sorry you've broken up, Peter.
Yes, Kim, could you perhaps mute?
Peter, you have a little bit of echo.
Yes, I'm echoing. I'm wondering whether it's because Kim's...
Oh, okay. Right. Try that.
Right, so I think if we're all mute, then I won't echo. And I must apologise. It's Peter Lacey here, currently chair of the UK System Dynamics Society. I was speaking over the introductory part before 10 o'clock, not realising that my microphone wasn't working, and then my Wi-Fi completely went down. So thank you very much, Douglas, for stepping in at the front end. It wasn't quite the plan, and thank you, Kim, for an excellent first contribution, which was spot on time. So thank you for that. We've also introduced you to menti.com, and you provided us with some expectations at the start of the session. We've got the code back up there now, and if you can start typing away your questions, we'll have maybe 10 minutes during which Kim can respond to those. So we'll ask him to unmute in a moment and answer those. Oops, Kim, that was your timer, That's how good you were on timing. So we'll just wait until people have some questions. It's incredible how similar, Kim, at least the decisions that we need to make, even though the context can be very different, are very transferable into very different geographic contexts. So really appreciate the way that you shared that in a very accessible way. Critical part of what system dynamics is about, to be able to communicate the structure of a system in order to understand and respond appropriately. So we're just waiting for one or two questions to come up. Often find that there's a pregnant pause and you wonder whether there's nothing, but I'm hoping that people are beavering away with their questions.
That's while we're waiting for questions, I might just mention some of the other cases people have worked on. I mentioned the young guy who calibrated the model for Jakarta back in mid-April. We have a friend has calibrated it for Hong Kong, where they have a similar issue, very, very high population density, not as high as Dharavi, but very high density indeed. And there their lockdown experience is pretty appalling. And they're desperately trying to find a way of keeping the disease at bay. So arrivals in Hong Kong are being quarantined, for example. So questions, sensitivity analysis. Yeah, the model allows you to set up the basic scenarios for any mix of parameters in the model that you want to change, and it's also set up with scenarios that you can create and put on the same chart. So that's essentially what you saw on the slides there. I should stress that, like all these models, it is incredibly sensitive. This is something I think very few people really do understand, that the exponential growth of an SIR model is shockingly sensitive to small differences. And the way we try to explain that to people is to say, imagine that you were being charged 200% interest on your credit card every 14 days. That's what an R of 2 actually no, it's actually worse than that. An R of 2 will give you more than 200% interest on your credit card every 14 days. But that's the kind of thing. So the difference between 20% and 15% is absolutely massive. The model does.
Yeah, carry on the questions.
Yeah, the model does allow you to put contact tracing in. It's a bit crude, to be frank, but it kind of works. Basically, you decide how many tests per day you're going to do, and it simply moves people out of the circulating population of people who are infectious, and it kind of moves them into a holding bucket from where they recover without infecting other people. Well, the biggest challenge for regional decision makers face for acting on the insight research. Well, the insights and challenges are hugely different depending on where you are. So the challenge in London now is very different than it is in Mumbai, and it's very different between those two. So yeah, it is all about how we get out of lockdown. The thing I find quite shocking, someone may know better than me about this, I do not understand at all why the UK government and its advisors have never been assertive about recommending the use of masks and gloves. I don't understand that at all. They say they don't have sufficient evidence of its effectiveness. But if it was only 20% effective, that would reduce R from, let us say, 1.1 to 0.9. And why would you not do that? Okay, Digits going, you better insights of the Imperial College model UK. Difficult to say, because we don't know exactly what insights the Imperial College model has been giving to the UK government. I believe that model is now publicly available on GitHub, but it's not a model that I think any kind of ordinary person would be able to do anything with. I think the main thing that our model does probably different is that we do split out the contact rate between people and the infectivity of those contacts. So that allows us to split out the impact of reducing the contact rate through travel restrictions or lockdown or whatever on the one hand, and things like hygiene measures on the other, masks and hand washing, elbow bumping and those things. Does the model reflect hold up to what's actually happened on real data? Yeah, all the cases I've told you about, I didn't actually show it in the presentation. Every one of those is matched to real data up to the point in time where we actually have it. And I don't think I've got time to show you an example, but we've matched the London data very closely, and we keep on matching every case that we do. The model allows you, by the way, to put that data into a separate time series in the model, and the first thing you do after putting the basic demographics of the region into the model is that you adjust those parameters for contact rates, for social distancing, so that it matches as best you can estimate what you think has actually been happening in the region, and matches the data. And we allow you to uprate the data for missing for underestimates. So, for example, in London, we uprated the case rate by 50% because the Office of National Statistics indicated that the reported case rate was probably 50%. Was probably understating by 50% the number of cases, and uprated the death rate by 20% for a similar reason. In cases like New York, I believe the estimate is that the death rate is underestimated by a factor of 3. SD models being ready to go partners to bring on it's big task. Well, the question of partners, yeah, that's what we're trying to do with Junior Achievement. It's what we're trying to do with PwC and Capgemini. We have a contact with the Greater London Authority. We're completely reliant on these partners. Isolated individuals like Maurice and myself can't do anything. I'm not familiar with the Salafé and Nikki case infographic on SCIR. Sounds great, and there are some really good infographics out there. What we essentially are urging is that there's one that people can actually put in information that relates to their circumstances. So is there any environmental factors on environmental factors? The model has got a number of parameters that allow you to adjust things for local conditions. So, for example, in the case of Dharavi, we know that there is a much higher mortality rate anyway than is typical. So you have the option to uprate or downrate the mortality for the area you're looking at. If you believe that there is, so there'll be big differences between a regional, a rural catchment area and a city. And that would be reflected simply in a very much lower contact rate between people in that area. If you believe, for example, that warmer, drier climates would be less friendly to the virus, then you can reduce the infectivity of the contacts between people. So can use demonstrate survey public decremental changes in effectiveness. And, so that what simple demonstrations can you give to the lay public? Well, we wouldn't. Our purpose is not to demonstrate things to the lay public. It's to give them a tool they can demonstrate it to themselves. They can put in a 10% reduction in normal social contact rates. That all they need to do is kind of drag them out across a chart. If we have more time, I could show that. But if you go to the model, you can see that for yourself. It's pretty easy. The Imperial College model is flu-based, not COVID-based. I don't happen to know whether that's true or not, but there are considerable similarities between these COVID series viruses. I should say, by the way, that we've been working with a professor of disease control who specialises in animal-human diseases at the Royal Veterinary College, a guy called Richard Cock. He's been very, very supportive, and we've had him and various other epidemiologists and disease experts leaning over our shoulder on all this. He's just submitted an article with us on the Mumbai Dharavi case to the Financial Times. So I do hope it'll get published. Obviously, no guarantee of that. Do you have an SD model? Yeah.
One or two questions.
Do you have an SD that connects SEIR and a policy like a lockdown? Well, that is what the model does. It connects the SEIR with the lockdown and containment strategies. What it doesn't do is we have not got any collateral impact on the economy or other things to do with people's more general welfare. We obviously had to acknowledge that in the Dharavi case, and I think the kind of widespread Dharavi Mumbai is simply symptomatic of probably thousands of cities around the world which have very, very poor districts right up against others. And the key insight there is you cannot lock down those districts. You just can't. You're basically giving people the choice between catching COVID and hopefully surviving it, or starving to death. I mean, that's just cruel. To be fair, every city that we've come across with this seems to be being much more intelligent about it than that crude lockdown policy might otherwise imply.
Okay, well, let's draw that to a close. We're spot on time for moving to our second presentation, but I just want to say a big thank you to Kim. That's been extremely instructive. The first comment on the questions was saying just that, so thank you for that. I would say that the presentations are being recorded and will be available after the event on YouTube, accessible via the UK System Dynamics Society webpage. So unfortunately on MS Teams we don't have the facility to clap like in other platforms, but I'm sure we will do it virtually, and thank Kim for that contribution. So we'll move on now to Mark Gregson, who's a consultant with the Whole Systems Partnership, who's been working in the Kent system. And Mark, I'm hoping that you've got ability there to share. Excellent. Thank you very much, Mark. Over to you.
Thank you, Peter. And I assume from your, you can see my screen there, is that right?
Correct, yes.
Lovely, I'll just kind of set everything up here. Thank you. Thank you, Peter, and thanks, Kim. I feel like I'm sandwiched between quite some esteemed speakers here, so I'll try and bridge the gap as best as I can and try and keep you engaged throughout until Erik later. I'm a consultant with Whole Systems Partnership. To give you a little bit of background and context of how we got into this work, we're doing some demand and capacity work across this particular health system, and at that time of when COVID came about and around the lockdown, our work basically stopped for obvious reasons. Is that the focus of all the work in the NHS shifted to COVID, and so our work, which required, engagement and analysis and things, all kind of stopped. But we were asked, could you do and provide and develop a local model, a local COVID model? They were told the NHS weren't going to particularly get locally seeded models, but there was going to be regional ones. And so they asked us to develop a whole system COVID additionality model. I'll talk through the question that we were asked, that we were looking to answer, a little bit about the team and development of the model, I'll talk a little bit about the initial kind of key kind of news question, which was how many ventilators do they need? Something about data and information, as always with modelling. Some long-term scenarios and some key reflections, and a little bit about the danger of castles. So just a couple of comments before I begin. Just these views and reflections are mine only. We are still continuing to support the system, and we are still using the model, but are developing it into what we would call a post-COVID model to look at how and the level of demand for services when coming out of COVID, and as the NHS starts to try and do business as usual in the new normal. I think we know as well that behind all of the numbers is loved ones, and we've all been impacted by COVID as well. And I think just to recognise that this isn't all over. Like I said, the NHS is still working through this. In respects to us, we aren't epidemiologists. I'm personally a paramedic, and this isn't going to be a technical piece. I do work with more technical colleagues. And my colleague has written a technical paper on this very recently, and it's not ready to share, but very close to sharing. And if you would want to read that, then do email me, and my email address will be at the end. And just an acknowledgement to IC Systems, who developed the software, Stellar Architect. That they kindly allowed us to use their initial COVID-19 model. And that was for our version 1, and you can view their simulator at the link below. So thank you to them. We did very quickly move our model on. We're now in version 4 comes out at the end of this week, but there were versions in between all of those numbers as well. So this was the key question, and just to read that out, it was to help local systems to plan for the capacity across a range of services in response to COVID-19. And in the context of social distancing policies and the early progression of the disease within a specific population. So the area of which we were modelling, it was called, and for those who aren't kind of embedded within modelling within healthcare in the UK, was called an integrated care system. Now this is what we would call the strategic health authority. Now this area was around 1.8 million. What we were asked to do was to develop 4 models at the ICT level. Sorry, I'm getting a bit of feedback there. Is that okay? That's gone. To develop outputs for the integrated care partnership level, and there was 4 of these within an ICS. Now, to get the ICS number, we would then add all of those up. But each of these models would have separate seeding. And also have different assumptions should they be required. Now that was important because two of the areas did border with London. We would want to provide outputs against reasonable what-if scenarios. We would need it to be rapid changing, rapid learning with new versions coming out as and when required on a daily basis if needs be, as and when the information came through. We would be using System Dynamics. That's the tool that we use as a consultancy, and we would need to be providing the kind of one-to-day nowcasting. So the question, how many ventilators do we need in 3 days? Because there was genuine kind of angst around what that number was going to be or what it was going to end up as, but also for then more so now is that kind of medium to long term planning of, okay, well, what do we need? What do we think we're going to need in the future? We can close down some of this kind of ICU capacity perhaps, or do we need to keep some of it? Do we need to keep them open, and how much do we need to keep open? And all of that is obviously scenario planning, and lots of it based on the national policy and social distancing guidelines that have been coming through from the government. Initially, we, as Kim demonstrated, we used and matched what the Imperial College model was doing, both with the assumptions and outputs at the national level. So our team, for the local team, there was a local COVID modelling lead locally, who was to work across the whole of the ICS. Now, luckily, we had been working with her over a period of a number of years. We had a good relationship. We had a kind of group that included consultants in public health, chief analysts, strategic analysts, and latterly some NHSI regional representation as well. Now, they were supporting the work that we were doing, checking and challenging, providing kind of key and emerging insights, discussions of the developments of the model, and really kind of setting kind of very, stringent kind of milestones and deadlines for work that needed to be done. And these were often, in that kind of late March, early April time, these were very much daily conversations with daily deadlines. And the WSP team comprised of 4 of us, all trained in SD with varying levels of proficiency. I would say I'm probably at the bottom of those 4. I'm less technical than my colleagues, and still definitely learning. We did have both the local team and WSP partway through the project had some support from some actuaries, and they have been supporting both the local teams in producing reports and developing macros and crunching some data for us, so that we can create this model for any local health system in the UK. And I think it's just important to note that none of their work was to be used for any commercial gain. So the work that they're doing allows us to create these local models completely free of charge for any health system at the ICP level. So what we thought was important to do from the offset, or around about the version 2, we recognised that we needed to create segmentation, and this has allowed us to provide different assumptions for each risk group, particularly when it came to around the effectiveness of social distancing measures. So we all know that, for instance, there is a shielded category that are at significant risk of harm from COVID, and these have been highlighted by the NHS at the very high level. They are instructed not to leave the house under any circumstances, and that any contact, particularly from healthcare visitors, would all be protecting themselves in order to then protect the shielded individual. Now, it's important to recognise the reason why we've done that is that the impact of that shielding would impact on the effectiveness of the measures for that group. If you consider those in the low risk group, which are most of the population, they will still be, despite being in lockdown, would still be potentially still going to work if necessary, potentially still going to the shops and doing shopping. So the social distancing effectiveness would not be as effective for those individuals. We also included the moderate risk, and those that aren't necessarily in the shielded group but are still at high risk. And these would be those that are over the age of 70 or those with long-term conditions. And this might be people with hypertension, diabetes, chronic lung disease, etc. But they won't necessarily have the level of protection from local services like the high-risk group. Certainly the high-risk group, we know, when I work as a paramedic, we know if they've been shielded because we ask them, have you received a letter from the NHS saying that you are a shielded patient? So we got that data from locally from an integrated data set or national age specific prevalence to understand the high risk groups. But broadly speaking, the low risk group is around 75% of the population. The high risk group there, which I think is, I can't see because I've got some recovery, is around 1%. We've learned that actually now that is higher. We think that's closer to maybe 3%, and we do need to input. We will be inputting those changes into version 4 of the model. So this is just the, I mean, you recognise the kind of the SERI model here, but it's just to demonstrate how the risk groups are segmented and arrayed across the SERI model. I won't dwell on this slide too much, but just to demonstrate some of the assumptions that might be different across some of the risk groups. For instance, the daily contacts in the low group will be higher than those in the moderate and high group. Those in the low group would contain most of young children who would have been necessarily going to school at the time, and those of working age who will be kind of travelling around and working, for instance. As well as the kind of in the model the impact of social distancing on these daily contacts. When someone is infected, it also affects their daily contacts as well. So just highlighting there that those with mild and moderate symptom contacts reduced by 50%. As you can imagine, when people get a cold, they might not necessarily go into work, they might just want to stay in bed. And certainly those with severe symptoms, which anyone with severe symptoms, we've said that go into hospital, you can imagine that they would not be going anywhere. They would either probably call an ambulance, be taken into A&E and be isolated in a hospital bed. So the impacts of the social distancing measures, here we've got the four scenarios across each of the risk profiles. These are quite crude at the minute and are quite sensitive to change. The model is sensitive to kind of small changes in these, and we are looking to develop this further. But there you can see how each of the scenarios have different levels of effectiveness for each of the risk groups, and then that affects ultimately the impact of the social distancing measures on the model. Here is the ultimate kind of outputs of what we wanted to get to. Really, this was a health system. They had some key questions that they kind of wanted answering, all of which are kind of here in mostly it's the kind of the square boxes. In the early stages, it was very much around, okay, what is it, how is this all going to impact on A&E 111? How the level of what's our capacity requirement in the GP hot hubs, where people would be referred to from 111 if they needed to be assessed by a GP, but with wearing suitable PPE. The question of the ventilator beds was always still there, and was always probably quite at the top question, really. Once people are admitted into hospital, the kind of the national guidance which came through from the centre was, and then this is how they did their modelling, was that they separated out. They had three kind of segments of how the hospital could measure what the demand was going to be, and they had people would either occupy a bed, an oxygen bed, they would occupy an O+ bed, which was a level of critical care but not needing a ventilator. So if you ever see people with one of those big masks on, they're still conscious, and it's called a CPAP, or positive airway pressure mask, or the numbers of ventilator beds. And anyone being admitted with COVID would be kind of would be placed into one of these beds and would have a stay in one of these beds. And the pathway might include all of a patient going on all of those beds. So we had a lot of assumptions, some assumptions from that came through from Imperial initially, and then we kind of went into a bit more detail about those once we had more data coming through. Other outputs included deaths. We needed to understand mortuary capacity, and then latterly pressure came into the hospital discharging pathways, and they needed to know what the capacity requirements across each of the kind of, they have here 3 to 4 pathways, and what was the capacity requirement in each of them. This was particularly important because they needed to understand that these patients were they weren't going to be coming out and being put in and mixed with other patients. They were still, for a period of time, needing to be isolated until they were absolutely certain that they were clear of COVID. So the first question in the system really was at the end of March, early April, was how many ventilators do they need? And at that time, or throughout the past years, the UK has had significantly less ICU beds per 1,000 when compared with other countries in the same economic bracket. And there's just a comparison between UK and Italy. So you can imagine there was quite a lot of nervousness that you probably all would have read about and such like. There was a good level of certainty, I think, and general consensus that the peak would be around the kind of mid-April. There was talk about all this changing, but the initial early NHS planning did say this, and our model was saying that. So we were quite confident in that. But they were really wanting to understand what their peak, so their peak at that particular hospital, what does their peak going to look like? Each hospital, not every hospital were able to surge to the same level, and some hospitals were only able to double their ICU capacity. Others were able to kind of triple and quadruple theirs. So it wasn't just necessarily about a particular hospital, because in a network, the hospitals might be able to share their capacity. So when do we think that if a hospital is going to come to reach capacity, do we think that they need to start sharing the capacity with other hospitals in the network? So I just wanted to show you. This is a slide that has the NHS regional planning lines on it, and our SD local planning. So this was the aggregated numbers of for the SD model, the aggregated ICP numbers, all 4 ICP numbers up to the ICS, adding them all up together, and you get the blue line. The blue dotted line is where we were estimating the ventilator demand would be required. The green bars are the actuals, the number of occupied ventilator beds. The dark blue line, the high dark blue line, is the regional planning number for that particular ICS. So the NHS only provided a regional planning number for the number of ventilators. Now this spanned across around population of around 8 million. Then this line here was then having to be, okay, well, what is this ICS proportion of that regional planning? And then this is the number that you need to be planned for. So you can see that original blue line is significantly higher than both the capacity that they were able to surge to and the SD model and their latter version 2 model. So you can imagine why they were thinking, oh, we need to have these Nightingale hospitals at the end of March. This is what they were thinking they were going to be getting across the UK, and it wasn't until kind of early April that they did a second version that kind of showed this grey line here that was to say, okay, actually I think we're gonna be okay. But it just demonstrated that really kind of this kind of regional model was just used from what I think was probably the London and Imperial model, and was really not suitable for kind of local planning. I'm a little bit short on time, so I'm not going to kind of dwell on this too much. I think just a little bit about kind of the data has always been a challenge. We were having to do a lot of triangulation. The data that we were getting through on a daily basis was often quite of poor quality in the early stages as well. And we had to make a decision as whether we were going to use that or not, or run or still continue to run with our current assumptions. What we realised was that not all patients who were being admitted were going to be suitable for ICU. And what we latterly realised is that those generally over the age of 80 were not suitable for being ventilated, and there was a kind of a palliative pathway that was within the hospital. But within the original assumptions in the Imperial paper, you can see that actually the percent hospitalised cases requiring critical care was around 70% for the over 80s, and that really in reality was just not the case. We're talking maybe like 3 or 4% of those over 80 were hospitalized cases were going through critical care. And so that was one key area that we recognised was causing this inflated number of ventilator beds. But yeah, using those assumptions, we were just not able to kind of triangulate the number of deaths that were occurring in the hospital, which was one point of triangulation that we were fairly certain on, because they were coming through on a daily basis and were fairly accurate, particularly in respects to the number of hospital deaths. And the number of community deaths has always been a bit of a challenge. So in respects of that was kind of more with the nowcasting. In respects of moving forward in the scenario planning, the orange line there, the orange peak there is the April peak, and now we're kind of, the questions are coming. Okay, well, what's the future going to look like? So we created a number of scenarios there, 1 to 4. I'm not going to necessarily read them out. They're all kind of reasonable. What I wanted to just suggest or talk about was the differences between two very local, two ICPs, which are hospitals that are next to each other geographically, and the difference in the scenarios, the scenario outputs for those ICPs. So the ICP B had a initial higher peak and had more infection within the population. Now, what that has now meant is that their second peak is unlikely to be higher than their first. Go to ICP A, which is just a hospital which is 27 miles away. They have a much larger susceptible population, we think, still, and actually they are at more risk of having a higher peak than their first, and significantly so. And I think this just highlights some of the comments that Kim was making around the need for having this local modelling, because to provide insights such as this. So some key reflections. I'm aware of time. I've got about a minute left. Yeah, daily inaccurate information driven locally, but be patient about changing the assumptions. We were getting daily data coming through. We weren't sure of its accuracy, and we were really kind of held tight before we started to change the assumptions that we had. We had levels of confidence in the assumptions that we did have. Yeah, we were having to work at speed, and we wouldn't have been able to do it if we didn't have a moderately sized team, both, I guess, internally with WSP and with the local team as well. I mean, we were internally all working on this as best we can. I mean, we've all had childcare issues like this time, but we were working flat out on this. Important to remain at that kind of strategic level. There would always be very, very local outbreaks happening in care homes. One happened within a hospital. And actually, we needed to kind of decide whether actually we were going to model that or not. But really, just try and keep pulling yourself up is my advice. I think one just key thing before I go to questions was we would have liked to have included kind of the risk groups within a setting from the beginning, because what we have found is, this issue around the care homes, that people, those high and moderate risk groups which are within a care setting are at higher risk of being infected of COVID-19, and we would have liked to have made that explicit within the model as well, so we were able to model that and understand the impact to things on the care homes. I'll leave it there. I think I've called this the danger of castles. I won't go into the reason why I've said that. I'm sure you'll all imagine why. But this is just to show that the impact of the social distancing measures. The blue line, the blue hump there is the April peak that we've just gone past. And if we hadn't have done anything, the peak would have carried on. And we would have had our peak in June, and it would have been significantly higher. You can see the model. You can play with the model. It's online at the link there. It was a generic 500,000 population model, and we've seeded it from the 9th of February. I won't say more of that, I'm aware of time, but there's my email address if you have any more questions. And if some of the questions that I can't answer today, just because of I'm not that technical. You can certainly email me and I'll pass them on to some of my more technical colleagues.
Thank you very much, Mark. The Mentimeter code is on the discussion chat, and I think James may well pull it up again. And we've about 10 minutes for questions before we move on to Erik. So interesting similarities from other sides of the world in terms of messages about local modelling. So we do have the first question.
Yeah, so regional model version 1, version 2, what triggered this? What was the critical change and how does this get relayed back to Imperial? I don't think that's necessary. I don't know. I really don't know. I think that they must have realised that the peak wasn't going to be as big. They must have been working on a version 2 and realised that actually, yeah, and that was the outputs. I can't really say any more than that. You know, we got that data through second hand. It wasn't through with any necessary information. Yeah, I can't. But I think it just demonstrates the need for the local modelling, or particularly just with. I said in my key reflections, really, though, they could have a national model, but it does need to be able to. The assumptions do need to be changed for local populations, both for local health and demographics, both with the seeding and with rates of infection. You know, some areas will have a faster rate of infection. Have you considered the impact on out-of-hospital demand for COVID patients being discharged from hospital? Yeah, we did do that. I did. I don't know if you saw the kind of conceptualization. One of our key outputs was understanding the different types of discharging of COVID patients, particularly understanding the number of community beds that we needed. Were these modelling insights used by decision makers managing these hospitals? Yes, I mean we don't produce two outputs now, but in the early stages we were producing 2 outputs per week, and they were reports being sent to all decision makers across the system. The feedback we got with it were all the reports were being useful. I think one key it's difficult to know how we'd have to speak to them directly to get an understanding of what necessarily had changed in their decision making. What I can say is one area around the kind of beginning of April time, there was a question. You know, they hadn't received this regional modelling yet, from what I understand, and they were nervous about were they going to be having enough ventilator beds. And at this point, the model was kind of saying, well, you need about 50% more than what you've currently got, and that was the kind of what we were saying back to them. The regional modelling was saying a lot higher, and we it was a difficult kind of conversation, really, because it's modelling. We can't be sure, but this is what we think, and then this is what it's saying. So I think that kind of influenced some decision making. Certainly around one of the hospitals, they were getting close to capacity, and I think it impacted on whether they were going to kind of shift patients, move patients between hospitals, and thankfully all the hospitals managed and coped without having to necessarily do any of that. Was the whole system conceptualization eventually arrayed for all 3 risk groups? Yes, the whole model is arrayed by risk groups. So you get the risk groups running right the way through, and so each even within the hospital, the assumptions on things like death rate, those that would go through a critical care, those would be ventilated. All of those assumptions are different for each of the risk groups. The data on some of that, though, is we are still getting data through on that, and so yeah, we're still tweaking. Opinions on another peak bump in September and October. I'll get my crystal ball out or my model. I don't think we're gonna. I'd like to think we're not gonna have another peak, another bump. I think that irrespective of loosening the lockdown, I think people know that they need to. They know how to socially distance, and they need to continue to socially distance, and I think that will continue. I think we were. I think in respects to the scenarios, we were kind of, those scenarios are based on kind of worst case, really, and we needed to produce them because hospitals need to plan for the worst case, because if they don't, they could get a little bit unstuck. Are you aware of any similar modelling undertaken for care homes? Would it have helped save lives in this setting? Yeah, I'm not aware of any modelling. No, we are hopefully going to be including that in the next version. I think it's probably potentially too late for those. Obviously, it's too late for the lives saved. I think you know, they've got their act together with care homes now, but I think it was all too little, too late, I'm afraid. Yeah, I think it would have. Yeah, I don't think there's anything more to say. I don't know. I mean, I know from a personal perspective, I still worked as a paramedic through that time. I was going into care homes, you know, fully kind of suited and booted in level 3 PPE, and staff and then everyone in there just weren't. They weren't in the peak of even in the peak of the virus. They were just carrying on as normal. They stopped people coming in, but inside it was just as normal. It felt like it was a bit sad, really. The important point about staying at the strategic level to be useful fast tool, opportunity to extend the model to explore returning to business as usual. Yes, we are using the tool. We will be using the tool to return into business as usual, and we are exploring that now. We've had a lot of interest from local systems to do that, and that needs to be done at pace. You noted that you waited until you were more sure about the data before changing parameters. Can you comment on the impact that this had for your modelling and on the lessons for ST practice? The data was so poor, and we didn't know, certainly some of the data that was coming through, we didn't know whether it was added from the data from because they hadn't inputted data the day before. We were getting this kind of second, third hand as well, so we weren't able to necessarily contact those inputting the data directly. With some of the intensive care, there was something called, I think they call it INOC audit, that was coming out, and that was really good in understanding and providing good data on intensive care and critical care. And if you're considering doing any modelling of COVID, I would go to there for some good data. I mean, I think they're now at around 10,000 patients that they've analysed. If there is another peak, it will be much sooner than September. I mean, that depends on a lot. It depends on a lot of things. I really don't think there's going to be a peak that we've seen. I'd like to think so, but I don't know.
Great, thank you, Mark.
Yeah,
We're good on time. Again, finishing there. Thank you for the questions that have been asked, and thank you for your preparation and presentation there. There were the opportunity to connect afterwards. I'm going to hand on. We're spot on time, so, and I can see Erik's there, ready to go, I'm hoping. So for our third finale of SD Meets COVID, I'll hand straight on to Erik.
Thank you very much. Thank you for also inviting me to talk. I'm gonna share my screen right away. Here we go. Do you see my screen by now?
Not yet, Erik.
Okay, just give me a second. Oh yeah, here we go. Okay. No. Yes. And then.
Yes, Erik, that's great. Thank you.
Yes. So, well, I have a very long title for this talk. From aggregated systems models towards integrated assessments models linking COVID-19 epidemics, economics, livelihood across multiple scales. And then I'm actually going to talk about 3 cases that I've been working on and still work on, which are Peru, Namibia, and the Netherlands. I made it also more methodological paper, and it has to do with the fact that at least for 2 of the countries, we're still really working for these countries, and I would actually not like to show any of the results here in this presentation when that goes up before I actually discuss that with the people over there. So a quick overview. I'll start with when I started, why I actually did that, and what I did. And so far, the order has been the Netherlands, where I actually live, then Namibia, because there was a request from Namibia, and then Peru, same thing happened there. And one of the things that I'm personally very interested in is the work on a world scale. And here already, I need to say immediately that I totally support, and I'm in line with the 2 previous speakers. These models need to be as local as possible, but and that's one of the methodological things I want to go into. We mostly make a whole lot of models, from coarse-grained to fine-grained, and also models that are multi-scale. So where, for instance, for a country model, there would be the national level, there would be provinces, there would be the constituencies or boroughs, whatever you want to call them. So that is, whenever I'm talking about a country model, then in most cases, not always, but in most cases, that basically means that we have built up a model all the way from the lowest possible level or scale up to the higher scale. Then why is it integrated assessment? Well, for a country like, for instance, the Netherlands, we are actually a very rich country, so we can actually, subsidize the whole economy while we are locking down society. But in many countries, that is not the case. So any measure you take will immediately affect a whole lot of people, livelihoods, the economy. And if that happens, then, and if we're only looking at the epidemiological side of things, then this might actually be, pretty one-dimensional, so to say. The focus would be on those who might end up in hospital, on intensive care, and those who might actually die. And well, in many countries, the measures that have been taken are actually way more lethal to a whole lot of other groups who do not actually get COVID-19. And so this is also why, at least for the other 2 projects, I immediately started to work on integrated assessment models beyond the epidemiological modeling. And then I'll tell you something about simulation under deep uncertainty, which we always do, but I'm not going to show you much about that in this presentation. Otherwise, we would be sitting here for much more time just to explain that. So, as I said, we worked on 3 cases, actually. So, when, why, what? Until last year, I was an associate professor at Delft University of Technology, and I had actually already been working there on many disease outbreaks. And one of the, relatively recent ones, or 2 of the recent ones, Ebola and Zika, we followed everything there, on a daily basis as well, checking all the data. And from that experience, I know that just following a moving target is actually very, very time consuming, and that the data is always very, very bad. Now, Ebola and Zika were not in the Netherlands, so my hopes were that in the Netherlands we would actually have much better data, especially because we have a very, very good health services and also a modeling team within the RIVM, which is the health organization in the Netherlands. So last year, I actually decided to quit my job as an associate professor at the university because I really wanted to spend my time modeling real issues and changing things in the world. And well, there you go. So we started the Peace Center, which is Center for Policy Exploration, Analysis and Simulation. And we, until now, we're mostly working on refugee issues and all sorts of environmental issues, preferably for governments. So we were working for some ministries that could actually have used our help on COVID modeling, but that never happened. And so this time, since there was no request for services, knowing that it's so time consuming and we had other work to do, I actually didn't jump in right at the start. And there are basically two reasons. I mean, time, and also knowing that there is a very good modeling team within the RIVM. I didn't actually feel the need to do any modeling, and I was relying pretty much on what they would be advising the government. Moreover, with simulation under deep uncertainty, what you typically see is that this could actually create panic. When I was about to share my my results during the Ebola crisis in Western Africa with the media, I had to actually pull everything back because of the fact that they were focusing on the worst case scenarios possible. But what we actually use it for is not to forecast a worst case scenario. We actually make a whole ensemble. We generate whole ensembles of scenarios, and then we use them to figure out what to do given all these potential futures. And so it's not actually to forecast, but the tendency is to then look at these outcomes and then take the worst and then start communicating them and creating a panic. So I didn't want to do that. But anyway, so at some point I got involved here, and that was basically when measures were taken in the Netherlands, and they were so tough, or they seemed to be so tough back then, that I really thought, oh my God, let's check this out and see whether this is actually what needs to be done. And then later that shifted into, after I modeled it for the Netherlands, and I was shocked at how phenomenally explosive this epidemic could be. This actually shifted, in my case, towards checking whether it was actually enough, because in the Netherlands we took quite a gamble, and luckily it worked out well. But then when I actually got the call from Namibia to help out there, Namibia is a very different country, not as densely populated as the Netherlands. Far from it, there are only very small patches of densely populated places there. So, and there was no COVID-19 epidemic there. So then the question actually becomes, what could be the potential effects of an epidemic, but also since they immediately went into a lockdown with 16 cases that were all isolated. What are the effects of a lockdown, especially in a country where many people are dependent, on their daily earnings to buy their food at night? So here what basically went on is that we shifted to simulating under deep uncertainty. So what to do in case of an outbreak. So it's actually anticipating how could you organize your system but also we made a multi-scale model because of, well, you actually want to see where and how you affect society and livelihoods. And then later, we actually started to collaborate also with Peru, and there they took measures right away at the outbreak, but then it's still raging on. So apparently measures were not enough, or they were actually not followed enough. I'll come back to that. Then, well, since we actually started with epidemics, then livelihoods, economies, culture. One of the main interests in, well, my life is actually what is the impact on the environment. And there are very interesting, well, that's a euphemism, effects on the environment, both positive, but also very, very negative. And I actually think that, whenever there are crises like these and crisis responses like these, then it's worthwhile looking at the longer term and on those dimensions as well that are not immediately related to the crisis. So that's the work we're probably going to do very soon. So first, fine-grained versus coarse-grained models. Also for the Netherlands, I immediately built a suite of models, and well, a suite of models basically all in the same model file, so I could actually, use any of them, or I could use a combination of them. But one of the reasons for actually starting with a suite of models is that the speed of development and deployment of just a coarse-grained model is something that we can do in hours to days. But a fine-grained model, where you go all the way down to each borough and people, jobs, and how society actually functions, that takes much more time. So, then it actually makes sense to start with the coarse-grained models and just focus first on the epidemics. And as already said by the other speakers, we know how to model epidemics, so that's really not something that needs to be figured out. And unless the other models are available, say an economic model that is really fine-grained, then you would have to build it from scratch. So in terms of speed of simulation, coarse mixes or less, and fine-grained models can easily take minutes and also there are in many cases very different purposes, such as, for instance, simulation of many scenarios, like under deep uncertainty. In that case, you want a model that is very fast, that can be simulated in no time. So that would actually be a case for coarse-grained models. Whereas when it is really about an outbreak that is happening locally, then you want to be able to test those measures and really fine-tune them for particular regions. And also for accuracy matters, the fine-grained models are much more important. So. I also mentioned that we mostly make multi-scale models, not always, but in many cases we would. So what I actually included here is, suppose I would actually make a model for London or for London boroughs, then I would most likely make a model for boroughs, but then I would actually include all sorts of other entities as well, and work on multiple scales, so that these a borough is not isolated, or London, like the greater London area, is not isolated from the regions around it, or the boroughs. So I would actually build it such in a hierarchy, but also in a way that places that are close to each other can actually have an influence on each other. Now, that could be either super time consuming if you actually do that by hand, but if you use some scripts and you would be doing that by instantiating these entities, each of those lower level skill models from a database, then it is actually something that can be done quite fast. The only thing that you then need are really good databases, and also taking case studies of different localities where you actually check whether what you presume is going on, that it is actually going on. So another item that I mentioned is that we make integrated assessment models. So let's focus here first of all on more or less, this is a simplistic version of the epidemics model. And what you actually see is, compared to the models that you've seen previously, is that I actually modeled the different let's call it symptomatic paths. So what you see here is people who would get infected can either remain asymptomatic, or they could actually become pre-symptomatic and then just get mild symptoms, or get mild symptoms and then heavy symptoms, or they could actually get mild symptoms, heavy symptoms, and extreme symptoms, critical symptoms, which really requires ventilators, and so intensive care capacity. Now, of course, this is just for modeling purposes. And it has to do with the fact that otherwise there would be different delay times, and you would get into trouble with percentages of people who first develop mild infection, then more heavy symptoms, followed by critical symptoms. So it's this is just a way of modeling that. And the second thing that is more specific than in most other models is that I included every time that people can actually either be isolated or remain unisolated, and in the more critical cases that you could either stay or not be isolated, or actually go to intensive care or to hospitals first and then to intensive care. But there it could also be that there's no place in intensive care, and that you would actually not end up there, but would remain next to intensive care. And especially in the critical cases, that has a big influence on the fatality. So fatality rates in different countries can really not be compared. And let me just give you an example. In the Netherlands, many elderly actually live in elderly homes, and so you could possibly shield them, but what actually happened is that they were not particularly well shielded, because the personal protection of people working in these elderly homes were really not good and taken care of at the beginning. So we had many of these places being, centers of infection. But, in that case, you would say, oh, then all these people need to go to intensive care, or at least those who get very critical symptoms. But then again, in the Netherlands, we actually don't have a lot of intensive care capacity. And we also have a policy that elderly who have, very severe diseases and, would actually be at the end of their lives, we are not actually going to treat them anymore. And this is something that happened here as well. Many people were discouraged from actually going to hospitals, or chose themselves not to go to hospitals. And this is also why the Netherlands is a very different country from, for instance, Italy, where all elderly, or many elderly, actually live with their families. So they would actually get it via family infection. And then the second difference with Italy would be that these elderly would all be hospitalized, and many would end up in intensive care units, and we didn't have that. So apart from that, from the infectious models, and that's like Mark also showed, I also would be modeling a health infrastructure, so hospital beds, ICUs, ventilators, nurses and doctors, and also the potential for it to go up or go down and really follow what is happening in a country or in a particular region. And then there are tons of potential policies in these models. Like lockdown, but also isolation, quarantine, social distancing, contact tracing. And then in the Netherlands, in the case of the Netherlands, for instance, I mainly used social distancing, but a lockdown, for instance, in Namibia, I would actually model in lockdowns because that's what was actually, implemented. But then in the case of Namibia, it is not just affecting potential infections, but it's really affecting the whole society and jobs, the possibility of actually making a living, and so on. So in those cases, yes?
Just giving you a 3 or 4 minute warning in order to allow time for questions at the end.
Oh my God. Only 3 minutes. Okay, good.
3 to 5 minutes, maybe.
Let me...
and James may well put the Mentimeter number up in the meeting chat as well. So you may need to race because I'm not quite sure how many slides.
Okay. I'll race. Yes. Okay. Simulation under uncertainty. So basically, we do sensitivity analysis, but then not to test the sensitivity of a model, but really to figure out what the potential futures might be. So in the case of the Netherlands. Well, I started really with the epidemiological modeling, and I followed everything on a day-to-day basis. But so data was really an issue. But even without that data, and I actually calculated a whole lot of data, but even with the, not so good data, it was clear that we were close to a tipping point with the social distancing measures that had been taken. And until, it was clear to me that we were actually on the good side, I was actually fearing we were on the bad side. I could not prove anything else. So until then, I was actually arguing for slightly more social distancing. But then at some point, it was clear that it was enough. And that point was really where most others would not actually see that. And that's where a model can really help to see that, in the remaining time, things are moving in the right direction. So we don't need to build any more emergency hospitals, for instance, which they kept on doing in the Netherlands. Let me then skip this. Let me go to some very simple graphs. Here you actually see the infections, and this is actually what I simulated just this weekend. So this is more or less what happened here. But you need to make a big distinction, of course, between the infections that are really happening. And by the way, you don't see them happening because it only appears later. But this would be the smooth infections in the Netherlands. Blue line is including also all the asymptomatic infections, because if I just simulate the model, and if I take these serological studies seriously, then we should be almost at 95% asymptomatic infections in the Netherlands. And the red ones would actually be the real infections. Now, on the right-hand side, you actually see how that evolved in terms of the IC capacity that we needed versus the data on that. And so actually the model captures it very well, but that is also because it's very detailed there. On the next graph is actually just the inflow into the IC capacity. And there was data was really not provided on people leaving the IC, so I had to kind of calculate and figure out how that worked. But that's just bathtub dynamics. So we all know that, but apparently people didn't understand it, and they were guessing about the IC capacity that would be needed. Now there is until just 1.5 weeks ago or 2 weeks ago, there was no data whatsoever on hospital capacity that was needed for COVID-19 patients, and it's only very recently that we saw that. But still, to me, it's a mystery why we have the behavior that we are seeing right now, and I cannot actually replicate that perfectly in the model because I don't have a clue why it is. I already told you about the hospitals, that we don't have a clue about the residence times of people in hospitals. We know about IC capacity, but not hospitals. Also, death in my model, the people who die in IC are perfectly matching the people who die in ICs in reality, but there's also a lot of people dying outside of ICs, and so mainly in elderly homes, and that's also why you see a difference here in the number of deaths. And then what I want to point at is that, and I already said that before, is that the number of people who actually recover are actually much higher than what we actually see because of all the asymptomatic infections. And so the red line is really the mild and asymptomatic infections versus the blue line, where you would include also the people who actually go through heavy or critical stages. So at some point, this is more or less the point where I pointed out, that's the red-blue line, that's the real data, where I pointed out that, okay, guys, from here on, it will go down. And it was clear because there was no way around it for me anymore, even under deep uncertainty. So, there are several extensions of this basic model, but let me skip that. And I need just another minute maybe for the two other cases. Is that good? Okay, so Namibia is a very different country, and so it's actually, you cannot just take this model and then use it just for another country because it's so sparsely populated except for some very densely populated areas. So I really had to rework this model to actually fit to the Namibian case. And that basically meant that I had to go really down to a much lower level of aggregation and then still bringing it together. And as I said, there is no outbreak so far. So it's more like, okay, what would you have to do if there would be an outbreak? And also, and the second thing, and that's very important for Namibia, is like, okay, if we actually have lockdowns now, what is going to happen in terms of livelihood and the economy? And that is pretty dramatic. So finally, then Peru. Well, that's yet another case. It's very interesting what is happening there, but it's also pretty bad because after China, Europe, and the US, now we have a major shift in outbreak towards Latin America. And Peru, although they took the right measures, or they took measures, let's put it that way, really at the beginning. And so there was some effect to it. What you're actually seeing now is that it's still growing exponentially, although a whole lot less, of course, than what would happen if you would not have any of these measures. But still, the question is, where does that come from? Is that either that the policies are not good, or is that because of the policies not being followed, and is this a cultural question? So we are really looking into this with the Instituto Andino de Sistemas, I cannot report much on that, but this is basically the ongoing project. So conclusions. I think basically in terms of data, this is really crucial. Data needs to be available almost instantly to actually allow modelers also to give much better insights in what is happening and what ought to be done. Policies for each place need to be adjusted to the local circumstances. Delays are super important in any respect, and and related to the regional remark already, regional intelligence needs to be there to just make sense of what is happening. So that's also why making a world model is actually an interesting plan, but is also almost a mission to be that is doomed. Thank you.
Thank you very much, Erik. Fascinating to see similarities as well as additional contributions. So I'm expecting James or Diego to bring up the questions as they've been appearing on Mentimeter, and hopefully we can take some of those questions for Erik. Thank you. Great.
So the question is hybrid simulation and OR. I hear an echo, by the way. Is this scenario, in this scenario, hemp used a carbon sink? Might it be correct to use SD for CO2, that's for manufacturing and for take up on farmers? Questions really is, also the question is really for farmers. Well, okay, I think it's a good question. I think we need to not just stick to SD models, and I think hybrid models are a way forward, although it also depends on the speed of development. So if there's a real crisis, then I'm much faster in developing SD models, but when it comes to capturing particular effects, I cannot capture them, and I would have to go to hybrid models. So in this case, these multi-scale models are still SD models in the formulation, but since you already build a hierarchy and actually define linkages between the different entities, it's not a pure SD model anymore. And so for a country like the Netherlands, I still feel okay to use a pure SD implementation, but already for other countries, I would not do that. And then either you make, again, an SD implementation for the local scale, like Kim defined it as, you know, hardly any interactions with what's around it, but most interactions actually really being in that area. Yeah, and so, and this applies also to some of the policies we cannot actually properly capture. For instance, the exact way in which tracing happens, or the exact way in which travel patterns can be broken. So either you do a whole lot of analysis on the side and bring your results in, or we actually need to have more hybrid versions of models. But so far, for instance, for rapid testing under extreme uncertainty, they are in many cases slow. So it's really a balance between what needs to be done. So second question, all presenters are building models with a generally agreed structure, but uncertainty on data input is key value in democratizing models, allowing a wider stakeholder group to reflect on the observed behavior and avoid closed thinking like imperial. Yeah, I really admire for instance, Kim's approach to actually have everybody toy around with models. But my experience is also that with complex models, and I actually think my model is already complex, especially the ones with, you know, economics in it and so on. They're really tough for people to use. They're even tough for me to use because I really need to still understand my model completely before I can actually properly use it. And then it also takes interpretation and a whole lot of looping in your work. If you see something that doesn't make much sense, then you need to dive in again. So where some people actually think that the modeling job is the biggest part of modeling and simulation, I actually think simulation is also a very big chunk of the whole thing. So once I have a model, then in this case, I would spend almost 50% of the time on data and data cleaning and working with data and getting it into the model and comparing it and figuring out what the hell is wrong with the data and so on, which, by the way, is almost always the case. Maybe, you know, maybe 25%, maybe 20% modeling, and the rest of it, 25 to 30%, would actually be simulation. And yeah, and I cannot actually, with these more refined models, get people to do that themselves. I would actually have to do it. Right now I'm almost done writing an ebook so that people can do it with my models, but I would actually get them to work through all the stages to become a modeler that can actually understand these models well enough. Third question, do you think modelers could contribute more to decision-making on COVID-19 responses? And if so, what should we improve about our practices to do so? Oh, I certainly think that modelers can contribute a whole lot to decision-making on COVID-19 responses, and especially not just the epidemiological part, but on the part to society, like economics, social, now everybody is just guessing at what is happening, and if you just look at the very insignificant assessments, or the assessments that were almost insignificant impact on the economy, and what we're actually seeing now, that it's actually gradually becoming worse, these assessments, I mean, that is something that we could already foresee, because we would know what, or not know, but to a large extent, we would be able to assess what might be happening, and then with measures taken, what the impact would be. But again, as I said before, the economics modeling and so on, that it takes way more time. So you either already have that, and that's also something that I think we need to be doing. We need to be anticipating as modelers what might actually happening, not per se like the next pandemic or something, but it's good to have really good models about the economy to actually use them whenever you would think you would, or whenever you would need them. So next question, can a model help experts to better use data from one region to another? If so, in what possible way? I think so, but the data remains something, yeah, data is in many cases really problematic, even if you are in a country or a place or a region where data is, you know, it should not be an issue. So I am, for instance, in the case of Namibia, where we didn't have an outbreak, a big outbreak yet, I would actually look at, you know, similar countries, for instance, regions in South Africa. But even then, I would consider data from one region or an outbreak from one region and the data on it. I would not necessarily immediately put it into another model. I would actually add a whole lot of uncertainty. Yeah, now the case of COVID-19 is actually, so to say, for modelers, an easy case because of the enormous asymptomatic spreading as well. So therefore, you almost get like these perfect, you know, behaviors in just like you would get in your simulation models. In many other models on different diseases, for instance, that would totally not be the case, and then everything would be dependent on super spreading events, for instance, in the case of Ebola. And in those cases, I would already not just use data from one region to another. Now, here in the case of this multi-scale modeling, what we would actually do is we would get really refined data, for instance, on the population, on their work, on, and we would be using that. And then the lower you go in your multi-scale setup, the more uncertainty there will be on what will actually be happening for real. So there, from that point, it's super data rich, but it also becomes way more uncertain what is really happening if you look at, you know, all these different places. And then if there would be an outbreak, my first response would be, oh yeah, but then we also need to have a local model, for instance, the models that Kim has used and shown, to really figure out what is going on there and just focus on that particular place. So not just work with one of these huge models that I'm making.
Right, thank you very much, Erik. Then very instructive, informative. I think if there is a sort of overarching comment about transferability, it is about the structure and the learning as much as it is about the data. I'll make a few concluding remarks, perhaps, and ask Diego, I think, is in control of the final Mentimeter, which will ask for your feedback. But as I say, thank you to all four presenters. It's been instructive. For me, the themes have been the importance of local models, the fact that there are a breadth of policy options and that they can effectively be replicated in these models depending on how one builds under the bonnet. And I think we've all learned, those who are practicing in system dynamics are quite open to learning from how we're making the models sensitive to those different assumptions. A number of folk have made the point about the high sensitivity of a model such as this. An epidemic is almost by definition, depending on its strength, clearly, but in the case of something like COVID, it is explosive. And therefore, in the early stages, any predictions are going to be quite sort of wide-ranging and uncertain. So highly sensitive, hence the importance from some of the presentations that we've seen of testing those sensitivities, but also the importance of aligning the model outputs with actuals, because the only certainty is what you see on the ground, barring data quality challenges, which we've already mentioned. So it is a process in the case of COVID-19 of significant unknowns. Working with local data, it's a finding out process rather than a solution identifying process, if you like. Although it does clearly need to inform policymakers. If I was reflecting on the UK, and these will be my views, not those of the society or anybody else, then I think what we've seen and heard might make us reflect on the reliance on a particular modelling approach that actually took quite a long time and then found difficult to translate down to regional and local areas. That's not to say that it wasn't a worthwhile piece of modelling, but had it been complemented by something that was perhaps more intuitive, we might have been able to respond at different timescales. The reliance on data in the UK and possibly elsewhere, when data is sparse and uncertain, is possibly a recipe for suboptimizing one's response. So I'm hoping that folk have found this morning interesting. I said at the start that the presentations will be available. They've been recorded. So if you go to the UK chapter System Dynamics Society website over the next day or so, you will find them there. I'm going to ask Diego or James to just share the screen for the final Mentimeter, which will ask for your feedback. And I'd like you to invite anybody who wants to stay for the AGM, which was the initial primary purpose of the meeting, suitably hijacked by COVID. But we are going to hold the annual general meeting for the society, which we couldn't hold at our annual conference a month or so ago, for obvious reasons. So thank you very much for your input. Thank you for your feedback. If you need to take a 5-minute comfort break, we will recommence with the annual general meeting at about 12:20.